move to the next presenter, which is Dr. Marcell Szasz. It's a pleasure to have him today here sharing his research. He's going to speak about tumors of the hepatopancreatobiliary system, contain the beast. So please, Dr. Szasz, go ahead. Sorry, we are not hearing you.
Thank you so much. Yes.
Yes.
Thank you for having me. And the professors, the ladies and gentlemen, I have the general task of the last speaker at the ICHS conferences, but I hope it will be worth to wait a little bit for this presentation. In the last pandemic era, we had to actually close down our treatment unit in March. And again, the numbers are rising. So we try to provide in the meantime further evidences and background about the tumors and summarize data and organize ourselves for the next occasions to be able to treat patients. So majority of our patients were pancreatic cancer patients, and obviously those which are from the GI side involving the liver, and I think it's really a beehive when you consider these tumors with this poor prognosis and really programmatic physiological and medical complications. So what can we ask in this topic? Is hyperthermia beneficial in these patients? Has it been investigated in these tumor types? And what about treatment response and local response and overall survival and the quality of life, of course? And do these treatments also improve laboratory data, namely liver functions, or not? So I try to provide an overview on the available literature and data in this field about three main tumor types. But what are our beasts actually? So as mentioned, this is like a beehive for the oncologist, and I think we have a lot of them. And there are many histological and biological types of them. But maybe the three main ones are the pancreatic tumors, the ductal adenocarcinoma, namely, the hepatocellular cancer, and the cholangiocellular tumors. So they all bite quite badly, and they all have poor prognosis. So if we consider them, the 5-year survival rates are very low. And in 2018, there are approximately 1.5 million new cases, mostly in the Far East. And depending on the region, the etiology of these tumors is variable from virus-induced to alcohol-induced to actually, for the most cases, idiopathic. And the deaths are 1.4 million every year, which means there is a little improvement in this care. So what's the problem with these tumors? They are in more advanced stage when we diagnose them. And usually with the liver function is declining, there are more complications, hyperproteinemia, hormones, you name it, we have it. So in the past decades, this was of course recognized, and several new techniques try to cure these tumors, but I think there is still no breakthrough, and we need to improve the care of these patients. So we performed the PubMed Medline search with the strings cholangiocarcinoma and hyperthermia, gallbladder cancer and hyperthermia, hepatocellular cancer and hyperthermia, and pancreatic cancer and hyperthermia, starting from 1964 to all the way earlier this year. And we have found 780 potential articles and 39 of them were selected. Additionally, we added the clinicaltrials.gov trials which we found, and altogether we had 47 publications. So initially we had 780, and through our filtering system, we ended up with 39 plus 8 subjects which we analyzed. So pancreatic cancer, how does it look like? As in this honeycomb, you can see that there are various patterns and various pieces, but it provides a big and chunky and really strong and thick extracellular matrix, which makes its treatment very challenging due to both the anatomic location and the physiology. So when we look at the treatment options, mostly we have upfront surgery for those who can be operated, but in Hungary it's less than 1/3 of the patients who are in earlier stages diagnosed. Most of them are in later stages or in metastatic setting. The baseline is actually the gemcitabine-based protocols and the FOLFIRINOX-based therapy, and really early hyperthermia was introduced in the metastatic and advanced stage pancreatic cancers. In this medical oncology field, what we see now is that even in this patient cohort, neoadjuvant setting is coming up, and recent clinical trials were published and summarized, and in the neoadjuvant setting, they didn't see too much of a difference between the FOLFIRINOX, the modified FOLFIRINOX therapy and the gemcitabine combined with nab-paclitaxel. This is not the case in the postoperative setting, so it was quite unexpected. So with the concomitant therapies, whole body hyperthermia has shown to improve blood cell counts, and was also observed that the effect was with carboplatin also in alone. This was not observed with the chemotherapy alone. So monthly cisplatin and gemcitabine with whole body hyperthermia was also combined in another study with low-dose interferon, which improved survival and a higher response rate locally. In another study, in advanced pancreatic cancer patients who had achieved a partial remission, they had longer survival than those who did not respond to this therapy. So with imaging, we can follow up and we can really measure the size of the tumor and the involvement of the organs, and it really seems to be prognostic to have even a partial remission with these treatments. And there is a clinical study ongoing with whole body hyperthermia and with chemotherapy, which we await the results of in the near future. So when we look at regional hyperthermia or local hyperthermia, it has a positive effect on survival and both therapeutic efficacy. And during the last decades, these were combined with hyperthermia, chemo, radio, and other therapies. And all of them reported actually better outcomes when implementing local hyperthermia to these patients. With immune stimulation, if we combine it, it also provides an even longer survival. So based on the talks before me, this is of course not surprising. In other studies with chemoradiotherapy and complementary hyperthermia, better disease control rates were observed in those who had hyperthermia, doubling observed responses to the treatment. So if we display this 4S plot, and you see the 0 is on the left, in pancreatic cancer patients, we have overall survival without hyperthermia in the middle line, or column, sorry, and with hyperthermia on the right. If you see the difference, is evidently towards the hyperthermia treatments, and it seems that we have a really, really good benefit of patients in this setting. I also show here the hepatocellular data and cholangiocellular carcinoma data, which also show the same improvement that we can expect for these patients. So when we still look back to the pancreatic cancer patients, the introduction of routine use of gemcitabine and FOLFIRINOX with several studies, regional hyperthermia combined, they have a better outcome. But gemcitabine alone had a worse survival when we compare the arm with the hyperthermia. And there is a previous observation whether increasing the power output would help and would cure these patients in a better way, but this was not confirmed in the studies, and we see that we have to apply the ordinary treatment, and elevating the power output won't help much more. With other chemotherapeutic agents like platinum and oxaliplatin, they have seen similar results. And there are the heat and heat pack studies ongoing, and we will see the results of them with the gemcitabine combined therapy for pancreatic cancer. There were other studies which contained herbal remedies from Germany and Italy and the Far East, and mistletoe and curcumin treatments were also involved, but these are just a few patient reports, and survived all of them more than 30 months, and no deaths were reported at time of publication. So I think these are really the best survivors which were reported in a cherry picking way a little bit. And with modulated electrohyperthermia, an evidently positive effect was seen, both for progression-free and overall survival, and an improved disease control rate. In metastatic tumors, including patients with ascites and metastasis, a better outcome was seen in patients. With traditional Chinese herbal remedy, when it was administered, it was also a positive effect on the tumors. When we look at the hepatocellular tumors, on the other hand, they really provide like this honeycomb pattern in the liver, and they have a different origin and different physiology and pathophysiology. In the early stage HCCs, we try to remove them, of course, or make microwave ablation, radiofrequency ablation, or other kind of embolization methods. For intermediate and advanced stage HCCs, we try to combine systemic therapies and also hyperthermia. And these methods, which were investigated, chemoradiotherapy, transarterial embolization, or transcatheter arterial embolization, evidently the earlier studies have shown a benefit of hyperthermia added to these treatments. And they also provided longer survival and also made laboratory results much better with improved results. According to one study, the best results were achieved if the intratumor temperature reached over 42 degrees, and if the tumors were located in the left lobe. Probably this is due to anatomic situation. And also they observed that the hyperthermia results were much better if they were combined with immunotherapy. So when combining local hyperthermia with other agents, embolization, or even remedies, they improve the laboratory results, the disease control rate, and even the progression-free and overall survival was much better with a lower 1-year recurrence and mortality rate. There was a third study which supplemented the above with the following, that there were also less toxicities to the environment, and the radiotherapy related gastroduodenal side effects were much lower. And they also confirmed also in HCC that increased power output did not add to the treatment efficiency in these tumors. And interestingly, it's known that the fever range temperatures improve the immune response against tumors, while tumoricidal temperatures inhibit host competence. Whole body hyperthermia at tumoricidal temperatures is considered to have an unfavorable effect on the immune system, while the regional hyperthermia, it does not suffer from these problematics. When they looked at investigation of CD4 plus and CD8 plus T and natural killer cell immunity after the treatment and after whole body hyperthermia, they revealed that anti-tumoral changes occur in those cells and last up to 2 months actually. So the fast movers or the first movers were the NK cells who responded to hyperthermia and improved the anti-tumoral immune effects. And it was followed by T-cell activation, the CD4 plus being slightly decreased and the CD8 plus being increased. What about cholangiocellular carcinoma? It's actually mixing probably both poor prognostic features of this location, and its treatment poses further challenges. So we had just a couple of these patients in our practice with actually very poor prognosis, I have to admit, with very short survival. Depending on the discovery of diagnosis, chemotherapy was administered, and most of them couldn't even attend more than 2 or 3 weeks of hyperthermia due to the decline of their condition. In the literature, confirming this, hyperthermia was the least studied in these tumor groups, in this tumor group, and the treatment options and results were very much similar to the pancreatic cancer and liver cancer cases. And until the mid-2000 years, no studies had been specifically designed to investigate hyperthermia in this patient group. And the studies on mixed tumors types were available, in which a few biliary cancer cases were presented. But from those little evidence that we have, it seems that we have a positive effect of hyperthermia on tumor response rate and even tumor markers. And also the survival was improved with combinatory hyperthermia and other methods which we use in the clinics. So it improves the treatment response rate and overall survival of cholangiocellular carcinoma cases, with an evident improvement in the quality of life and improved laboratory results. So here I just show the difference in disease control rates, which is not as far right as in the with the overall survival, but we can see that there is an evident shift towards hyperthermia in these patient cohorts in pancreatic, hepatocellular, or cholangiocarcinoma cases. So what we can conclude here is that adjuvant hyperthermia is beneficial in hepatopancreatobiliary cancers because both of its direct thermal and indirect immunological effects. There is an increased treatment response locally, also supplemented with prolonged survival and improved laboratory and quality of life data that were also observed in several randomized and observational clinical trials of the various hyperthermia methods. regional hyperthermia and modulated electrohyperthermia is more advantageous and more accepted among patients than whole body hyperthermia. However, we don't have actually the personal practice with whole body hyperthermia, and it's not yet a routine method even in Hungary. So we only have a few centers who have this expertise. And what I think we need a redefined or subdivided staging category for stage 4 tumors. And it would be very beneficial for the patients for a better stratification. Just think about the cholangiocellular cases who are maybe not prone to respond to therapy up front. We should have a stratification to provide the best possible treatment for our patients for their benefit. And thank you for your attention.
So thank you so much, Marcell. I think your review is very complete and you have a lot of knowledge about this. So yeah, I would like to share that we have treated a lot of pancreatic cancer cases, but also some cholangiocarcinoma cases with chemotherapy. And we have very good results because the results, they have longer survival. Maybe we have like 8-9 patients, not so much because it's not a very common cancer. But surprisingly, they are doing very well combined with chemotherapy, with first line and second line chemotherapy. So for me, this is like very exciting to go on researching on this. And the other thing is that I also agree with you about metastatic patients because many times they say, okay, no, this patient is not candidate for hyperthermia because it's an advanced disease, he has metastatic disease, but many times we can treat the metastatic disease, the macroscopic part, because if you have pancreatic cancer and liver metastasis, we can treat everything. So I agree with you that maybe we need another stage for those patients, okay? And I would like to ask you something from your clinical experience, because sometimes when we have patients that have liver metastasis from pancreatic cancer, for example, and they have bilirubin levels very high, and they cannot receive chemotherapy because of that. They have an stent, but despite everything, they cannot receive chemotherapy. We have tried treating them in monotherapy with modulated electrohyperthermia, and sometimes a very few percentage of the cases, but sometimes we are able to decrease that bilirubin levels, and then the patient can receive chemotherapy. So do you have any experience about that, treating in monotherapy with hyperthermia to treat later with chemotherapy or something like that?
Yes, we had a few cases. Well, not just a few, but we have many cases who are not subject to chemotherapy, so we cannot administer for various reasons. ECOG status is maybe over 2, or we have other comorbidities or liver function that wouldn't cope with systemic therapy. So we had a few dozens of those pancreatic cancer patients. I think maybe 20 or a little less, and we did observe that with improvement, or in those who have a tumor response, the liver enzymes also improved, not only bilirubin levels, but also the AST, ALT, and the rest. But we consider this just kind of a physiological recovery when the tumor effect was a little bit eased.
And in those cases, do you combine the treatment with anything else, vitamin C, I don't know, any other support for the patient, or just hyperthermia?
We just had hyperthermia for them. Actually, we treated them for good. and we didn't switch back to chemotherapy in these patients. We try to look at clinical trials, whether we can enroll them somehow, even though with this prehistory. But most of them we just treated for a longer time, actually.
Okay,
And
yeah.
they were kind of happy with that.
Sounds great, yeah. What we are also doing sometimes is when we have a massive metastatic liver, we are treating the whole liver with low-dose radiotherapy combined with hyperthermia, and we are having very good results because patients improve, and then you can do much more things. They improve, the quality of life is much better. And I think it's also interesting because we have spoken a lot today about how hyperthermia can increase the results from chemotherapy and radiotherapy. And I think that we can use radiotherapy much more with low-dose radiotherapy combined with hyperthermia for radiation, for a big tumor. So I think that this can be also very, very interesting.
This is very, very exciting. I think that we step towards a lower dose in both medical oncology and radiation oncology, and we supplement it with hyperthermia, and we have much better results due to the safety profile and the benefit of them. Yeah, it's very interesting, I think, and I have the vision to have more patients with locations after surgery. They are resected, like rectal and esophageal cancer. So if we can somehow evaluate their histology without removing the tissue, so not causing a huge decrease in quality of life, maybe we will have the same effect in surgery.
Yeah.
So less operations, not against the surgeons, but I think quality of life is very important, and looking into tissues with infrared microscopy supplemented with circulating ctDNA, I think could be a way forward in the future.
Yeah, I agree with you that maybe combining things, we can have better results with less side effects and better quality of life. I think this is really interesting. So again, thank you so much